Welcome back to Breathe Easy and continuing our A through F bundle series. Today we're covering the letter D, delirium, assessment, prevention, and management. When we think about critical illness, our minds often go straight to oxygenation, ventilation, hemodynamics, and blood gases. But one of the most common and harmful complications in the ICU is not found on a ventilator graphic. It is delirium. This episode is about why delirium matters to respiratory therapists and how RTs can influence prevention every single day. By the end of this episode, we should be able to define delirium, describe why delirium affects ventilator management, identify respiratory therapist interventions that support prevention and management, and explain how delirium assessment fits into the full A through F bundle. The goal is not to turn respiratory therapists into delirium experts. The goal is to connect what we already do at the bedside with better brain, lung, and recovery outcomes. Here's the opening story. Think about Miss J. She recently passed her spontaneous breathing trial and has done so more than once. Oxygenation is acceptable, ventilator mechanics are not the main issue, but every day extubation gets delayed because she's either too agitated to safely proceed or too withdrawn and unable to participate. That's where delirium becomes more than a mental status issue, and it becomes a respiratory care issue, a mobility issue, and a recovery issue. Delirium is an acute change in mental status. It often includes inattention, altered level of consciousness, disorganized thinking, and fluctuating course. It can be hyperactive, where the patient is restless and agitated, and it also can be hypoactive, where the patient is quiet, withdrawn, or difficult to engage, or it can be mixed. A key point for the bedside is that delirium is not simply confusion, it is acute brain dysfunction, and in critical care, it's linked to ventilation, mobility, safety, and recovery. Respiratory therapists should care because delirium affects our daily work. A delirious patient may need more sedation. More sedation can make it harder to complete spontaneous awakening and breathing trials. Agitation can lead to ventilator dyssynchrony or safety concerns, and hypoactive delirium can make the patient unable to engage in coughing, mobilizing, and participating in care. So the practical respiratory therapist lens is this: if the brain cannot participate, the lungs may not be able to liberate. Some delirium risk factors are not modifiable, such as advanced age, baseline cognitive impairment, severe illness, or neurological injury. But many risk factors are modifiable or influenced by the care environment. These include deep sedation, sleep disruption, immobility, uncontrolled pain, restraints, sensory deprivation, and lack of coordination around SATs and SBTs. Respiratory therapists may not own every part of the delirium assessment, but we do influence multiple parts of delirium prevention. The D element does not stand alone. Delirium prevention is strengthened when the full A through F bundle is practiced together. Pain is assessed and managed, SATs and SBTs are coordinated, analgesia and sedation choices support lighter sedation when clinically appropriate, delirium is assessed, prevented, and managed, early mobility moves the patient forward, and family engagement brings orientation, reassurance, and individualized knowledge to the bedside. The bundle creates a shared rhythm for the team. Here are some practical actions. Coordinate SAT and SBT readiness. If the patient is safe to wake up and breathe, the conversation matters. Speak up about ventilator synchrony because discomfort can drive agitation and lead to sedation escalation. Support mobility by planning tubing, oxygen delivery, airway security, and ventilator support. Promote orientation with simple actions like daylight, glasses, hearing aids, family voices, and clear coaching, and report behavior changes. New agitation matters, but so does a patient who is suddenly quiet, withdrawn, or harder to engage. This is a clinical pearl for the episode. One of the most common misconceptions in critical care is that a calm patient must be doing well, and a patient who's quiet, disengaged, inattentive, or hard to arouse may be experiencing hypoactive delirium. Hyperactive delirium gets attention because the patient may be pulling at tubes or trying to climb out of bed. Hypoactive delirium can be overlooked because the patient seems so calm. So don't confuse the stillness with recovery. Delirium prevention is team-based. Nursing often leads formal delirium screening, sleep promotion, pain assessment, and safety needs. Respiratory therapists contribute to wake up and breathe readiness, ventilator comfort, airway security, mobility support. Rehab helps progress activity. Providers and pharmacy help evaluate reversible causes and align the sedation plan. Families can provide orientation, reassurance, and patient-specific insight. The power of the bundle is that everyone has a role. The take-home message is this: delirium is not simply confusion, it's an acute brain dysfunction that affects the ventilator liberation, mobility, safety, and recovery. RTs are not bystanders in delirium prevention. Every interaction is an opportunity to support wakefulness, comfort, mobility, orientation, and communication across the team. When we help the patient breathe, we also help the patient wake, participate, and recover. Thanks for joining this episode. In the next episode of Breathe Easy, we're going to be moving to the letter E for early mobility and exercise. And we'll talk about how moving patients earlier and more intentionally can help improve respiratory outcomes, support liberation, and help patients recover beyond the ventilator. Until next time, keep learning, keep leading, and keep making every breath count.